I thank all of you for joining us today. My name is Anissa Mitchell, and we are going to be talking today about taking back control, a new way of identifying symptom fluctuations. This is a partnership that we have with our friends with Amneal. It is actually a third program in a series that we have been doing with them around different perspectives of off. And if you joined us for our last program that we did that was focused from the care partner perspective, we had a conversation around what it was like for them as care partners to understand and often how it is impacting them. And in fact, we focused some of the conversation around some poll questions that we had in a focus group, which I thought was pretty interesting. We found 53% of our care partners indicate off sometimes make them compromise or change their plans. 53% indicated that their loved ones' symptom fluctuations make them feel frustrated and discouraged. And 46% indicated they've never, ever discussed the impact of their loved one's symptoms on their life with the treating physician. And we know that it impacts quality of life for both the person living with the fluctuations as well as the family member. So today we want to talk about a new approach of identifying symptom fluctuations to help you understand the complexity and the nuances of them, the importance of being able to have that conversation with a physician, because it does have a significant impact on quality of life. And even though we talk about off a lot and we talk about symptom fluctuations a lot, it is a very complex experience for people, and it's still hard to communicate. So with us today is a friend of mine, Dr. Ramon Gil. He's a movement disorder specialist. You may have seen him on our programs before. We enjoy having him on here. He is president and principal investigator of the Parkinson's Disease Treatment Center of Southwest Florida down in Port Charlotte. He has been not only a treating physician, but a principal investigator of hundreds of clinical trials, primarily focusing on Parkinson's disease, as well as tremor, cervical dystonia, Alzheimer's, and other dementias, and spasticity. And he has come up with a concept of understanding the expressions of off, that experience that I think is unique and I feel would be helpful for people. And so he's going to be sharing his concept today. So I'm going to welcome you, Dr. Gil, and pass this over to you. And in the meantime, please open up your chat and your questions can be put there, and we will hold those until the end because we definitely want to be able to address those.
Okay. Well, thank you, Anissa, for that introduction. I am trying to get my presentation ready for you guys. Now, is that okay there? Everybody's ready. Okay, perfect. Well, first of all, I hope that you guys enjoy a great Thanksgiving celebration. I had a beautiful time in the mountains of Maryland, in the western part of the state, with all my kids and grandchildren. And it was great. It was great. And I hope you enjoyed and celebrate that beautiful occasion that Thanksgiving is. We really have a lot to thank God for, including our challenges. I started my week looking at a video of Michael J. Fox accepting an award by the Academy in Hollywood. And it was very inspirational. If you haven't watched it, I encourage you to look for it. And it's very interesting and inspiring because you are going to see a person that had a very hard time dealing with the reality of having Parkinson's disease as a youngster. He was 29 or 30-year-old when he was diagnosed. And he, as a master, was able to turn what was a big impact, a negative impact in his life, he has transformed in an amazing source of help, assistance, teaching, learning, hopes, and strength for all of us. His foundation has by now brought together $1.5 billion for research and services for the Parkinson's community. And just like the PMD Alliance, he won't stop, and his organization won't stop until we not just necessarily find a cure for Parkinson's disease, but when we all feel satisfied and content with the fact that all of you patients with Parkinson's disease out there and your caregivers are receiving optimal care. And by that, I mean optimal. We cannot be happy with our diabetes if the hemoglobin A1C is 6.8 or 7%. You could be on medication, but you need optimal control. And the same thing is required in Parkinson's disease. We in this country have all the resources that we need. We have to work harder sometimes to find the right place to receive services, but we do have that, and I want to assure you of that. Now, the best tool for you patients and family members out there is education. And I won't stop saying that. I saw a patient yesterday. My last patient in the afternoon was a 68-year-old nice gentleman that came here with his wife. And he was, quote unquote, diagnosed with Parkinson's disease 6 years ago. Now, he was diagnosed 6 years ago when his primary care physician said, gee, you are slowing down. Gee, you are kind of having problems with your balance. I see you using a cane. Oh my goodness, don't tell me that you are falling that often. So with that presentation, oh my goodness, you're also shaking in your hands. So you must have Parkinson's. Send the patient to a neurologist, and he was diagnosed with Parkinson's after they did a famous DAT scan. And the DAT scan showed, oh yes, it's positive. Now, what is the sad reality? Well, the sad reality is that if you guys have attended educational programs and you have learned about Parkinson's disease, you will know that nobody should present to the doctors with early Parkinson's and the presentation being false. So what does that mean? That in this particular case, this patient, by the time he was diagnosed with Parkinson's, his Parkinson's was advanced. And that cannot happen in this country as long as you are seeing a physician once, twice, 3 times a year. Well, you want to hear more to kind of get you motivated about learning and sharing information and fighting for your rights? This poor guy, 3 years into his falls and Parkinson's diagnosis, which by the way, he improved with medication. He got Libodopa. Well, guess what? He became forgetful, and not only forgetful, but confused. And he was also hallucinating. And he was experiencing delusions, which I'm sure you have heard about these terms before in some of the programs through the PMD Alliance. So guess what happened to him? You know what happened to him? Nothing. For 3 years, he has been hallucinating, confused, delusional. holding to ideas in his mind, including about his wife and not recognizing his wife. So they say, oh, he's demented. Well, 3 years ago, they did a neuropsychological evaluation and he was not demented. He was just having psychosis, never recognized and never treated. So he came yesterday. By now, I do believe he has mild dementia and he also has psychosis. And for the first time in 3 years, those things have been addressed for the first time. And you know what that did for 3 years? What about something called quality of life? Not just for him, but for the spouse. So I'm telling you guys, these presentations should be instigators, should be like a motivational presentations, sometimes to get you angry, sometimes to say, you know, shoot, I should do better. They shouldn't be just for you to sit in front of the computer, which I hate these days because I love live presentations. This is a little bit boring, you know, looking at a screen for 1 hour. But this should be a source of motivation for you to question how well treated you are, how much you understand this disease, and how much of a optimized treatment you are getting. Anyways, having said that, I'm going to go ahead and talk to you about the off and on and more in Parkinson's, okay? So the objective of this presentation, by the way, I should say thank you, PMD Alliance, for inviting me to talk. And thank you, Neil, for helping PMD Alliance to bring these programs together. This program is purely educational in the sense that this is not promoting any particular drug. I will be showing you some slides about some of the drugs that we use. And by the way, I am not receiving a single penny for this. And the great government of ours doesn't even allow me to deduct this from my taxes. So, hey, what a great deal here. Objective, I am going to talk about what is a motor response. You need to understand what we mean by motor response. I'm going to talk to you and try to help you to understand what motor fluctuations are. What is the so-called wearing off? What are the off periods? How to recognize dyskinesias. I'm also going to talk about the impact of motor complications in your life and your activities of daily living. I am also going to review for you brief information about some of the drugs that we use and clinical trials that we are currently conducting to help you with these problems. Okay. This slide, I am sure you have seen in many of your presentations. It basically describes how the response to Libodopa treatment in early Parkinson's is. You take Libodopa, Libodopa goes up in your bloodstream, and you have a beautiful response when your symptoms of Parkinson's improve for 2, 3, 4, 5 hours. It's called the honeymoon period. Everything works, even holy water. Then, as the disease progresses, it is required a better adjustment in the dose of your medications because you need a higher dose to get a beneficial response and reduce your symptoms of Parkinson's. But when your Libodopa concentration goes beyond this point, you develop at this time what is called peak dyskinesias, or involuntary twisting movements of your upper body typically, that may or may not include grimacing and other facial gestures. And that then slows down as the concentration of the Libodopa goes down, and eventually the patients then go off again, or the symptoms re-emerge because you don't have enough Libodopa in your system. Now, if you remember when your doctor say, hey, you need Libodopa, and they gave you immediate release, carbidopa, libodopa, 25/100, 3 times a day. Sometime later, they say, hey, you need it 4 times a day. And why will he give it to you 4 times a day? Very simple, because 3 times a day wasn't lasting enough, wasn't covering. So the medication was not lasting 5 hours, but less. And then as the disease progresses, we have even more problems because you need higher concentration of the medications to get the benefit, and then you cannot stop the increase in the concentration of the drug beyond this level, and patients have more dyskinesias. And then the time that you spend with a good quality on or response to the medication is shortened. And that's when you go into this yo-yo that some of you may have experienced, taking the carbidopa, libodopa 4, 5, 6 times a day, and then you go on dyskinesias, less, off, on dyskinesias, better, off, and you go up and down all day long. That is not ideal control. That is not good. The brain does not like these yo-yos. The brain doesn't like these, what we call pulsatile stimulation. So what are the off episodes? These are periods in the day when your medications are not working properly, when you don't have enough concentration of these drugs, particularly Libodopa, which is the main drug that we use to treat Parkinson's disease. Granted, we also have dopamine agonists that last longer, but eventually everybody will need Libodopa because the benefit of the dopamine agonist is not enough, or you are experiencing intolerable side effect from these drugs. So the off episodes may present in many ways. A very typical way for patients to experience an off time is in the morning. When they wake up in the morning, they have no medications on board, and we call that the morning off or the morning akinesia. Like akinesia means no movement. You are also often experiencing what we call wearing off. You take the medication, the symptoms improve, and then as the time to the next dose comes closer, you are losing the benefit of the medication and you are wearing off. Now, there are predictable off time, like some of you say, well, Dr. Gil, I'm taking my medication 4 hours apart, and guess what? I know that if my next dose of medication is at 12 noon, gee, by 11, my tremor seems to start coming back. By 10:30, 11:30, it is there. And I'm telling you, I can't wait for my 12 noon dose to come because I am very symptomatic. That is a predictable off. However, some people experience also unpredictable off, and all of a sudden, in the middle of a dose, they seem to be losing the benefit, and I don't know why I am off. There are patients who experience what is called dose failure or a skip dose phenomenon. Those are patients that they take the medication. Dr. Gil, my husband took the noon time of the medication, and I'll tell you, it was like nothing happened. It's like he didn't take anything. He was very off all afternoon. That is typically due to either stomach problems, like the stomach is too slow moving the content out of there, so the medication stay there and it's not absorbed by the small intestine. Or sometimes, if by mistake you take your medication with a high content protein meal, the protein will interfere with the absorption of Libodopa. And finally, you have a delay on, which means that when patients take the medication, it takes them, my goodness, 1.5, 2 hours to experience some symptom relief. Now, here is a patient that is off. You see him slow, shuffling, doesn't swing his arms. He turns in blocks, so he turns like with a few baby steps. And the off periods, it may be characterized by reemergence of your tremor, the slowness, but they also are characterized often by non-motor symptoms like anxiety. You become more depressed, apprehensive. You may become sweaty or drenching sweats, you may experience fatigue, tiredness. Even cognitive impairment is seen in patients when they are off. And they could happen at any time throughout the course of Parkinson's. Clearly, the frequency of the off periods increase over time because your brain produces less dopamine, you depend more on your medications, and that's why it is so critical to have optimal drug therapy as your disease progresses to minimize the disability imposed by this. Now, I have a question for you guys. Do you recognize some of these symptoms, or do you recognize this type of phenomenon happening to you? Do they tend to occur in the morning more in the afternoon, or do you have these problems for more hours a day than what you would like? These are things that you have to think and discuss with your doctors. How do these symptoms affect you? When you go to your doctor, you are there to be helped. You go there to get better. If you are experiencing, more off time than what you feel you deserve, if I may use that term, say. Don't just say to the doctor, oh, I'm having no new problems. I have Parkinson's. I know that I'm not going to be cured, and get refills. You have to really say, you know what? I am experiencing 3-4 hours of off time a day, and I am very impaired when I have those. Or, I have to plan everything according with my medication, because God forbid, if I am in the bank in the afternoon and I go in the off time, I won't be able to function. So you have to express these things to you. Now, look at the same patient in the on state. Look at him, much better walking. See? Swinging of the arms, better speed, better facial expressions. So that is what you expect to see when you are well treated. Don't be satisfied with mediocrity. Don't be satisfied with, suboptimal results. Educate yourself, demand better treatment. Now, in the on time or the on state, the medications are working, your symptoms are diminished, your functional status improve, you depend less of your spouse, or you don't have any disability if you are enjoying a good on. You're able to do everything. Now, on doesn't just mean, oh, my medications are working. The quality of the on is also important, okay? So you need to look into that and determine that. I cannot tell you what is your best on. You have to realize that you're on, and then you need to maintain always your best on as long as possible with the help of your doctors. Now, because we talk about the quality of the on time, and because we talk about the severity of the off time, I always talk about on and off, or motor fluctuations, not like this type of switch that is like on and off. I talk about these motor fluctuations more as a dimmer switch. It's a dimmer switch that we bring all the way down, and then you are completely off, or we bring to the best quality on, which if we go from 0 to 10, okay, 0 completely off, and 10 is the highest intensity of the light, 7 is the perfect on, but then 10, you're gonna have disabling dyskinesias, and we'll go through that in a moment, okay? So here is the picture of the flyer that we created, and it is being improved with the help of a few people, including some friends of the PMD Alliance. And the idea is that you have 0 to 10 as grades of motor response. When you are, well, where's my, when you are 0, you are completely off. Then 1 and 2 are still off periods or off states, but obviously 1 is a little bit better or less off than 0. Same thing with 2. Now, 3 is a transition to on. It's like when your medications start working. And then you have 4, 5, 6, 7. All of these are improving quality in the on state, 7 being the best on time. 7 is the lucky 7, the best number in the house. That is the best on that you guys are able to achieve with your treatment without dyskinesias. Then you have 8, which is on, the light's still on, but I'm bringing it up and it's a little brighter than what I would like. So you have mild dyskinesias. 9 is moderate dyskinesias. And 10, the light is so bright that is blinding. I can't function with this dyskinesia. And then in the back of the flyer, I describe in more details each one of these levels of motor response, okay? 0 to 10. Now, I make a couple of comments here and there, including that you need to keep in mind, guys, that tremor is not present in all patients with Parkinson's. And you need to keep in mind that up to 25% of patients with tremor in Parkinson's don't get satisfactory response with medications only. So it is a potential mistake for you to judge whether you are on or off based solely in the presence of tremor or absence of that, okay? So keep that in mind because tremor could be tricky and difficult to control with medications only. That is why you should have a dialogue with your doctors about deep brain stimulation early on if your tremor is bothersome, disabling, and not responsive to medications, okay? So question that you should ask yourself, you know, how do you feel first thing in the morning? How often during the daytime you encounter situations like this off periods that I'm describing there? Do you discuss these problems with your treating physician the last time that you were there? So you have to ask yourself those things. Here then you have the description of the on time. Okay, 3 is the transition. It's like, oh gee, my medications are finally starting to work. I feel a little better. And as your symptoms continue to improve, you go through a 4, 5, 6 to the best on, which is 7. Ideally, everybody being treated for Parkinson's should achieve a 7 or close to 7 in every cycle of medication. That is the goal. And unless you request that, unless you are educated enough to demand these things or talk to your doctors about it, you won't be able to get it. You know, it is what it is. If you don't ask, you don't get. All right. Okay. So how much improvement in your symptoms are you getting with your medications? Are your motor symptoms all minimized? Do you experience dyskinesia? These are very important questions that you guys have to ask yourself. And more important, is your functional status optimized? Functional status is a key requirement for us to judge the response to our treatment. I don't care about, let's say, one particular symptom of your Parkinson's. I care as a whole. I care about your functioning every day. I don't care to control your tremor to satisfaction, but then the price to pay is you are completely disoriented, confused, or hallucinating because I am over medicating you, trying to control your tremor, okay? And here is the top part of the dimmer 8, 9, and 10, which are on state, but with dyskinesias, which are mild, moderate, or severe. Now, the patient that I saw yesterday, believe it or not, at the end of our meeting, he was having peak dyskinesias, and he was having not only neck movements and trunk movement, but his respiratory rhythm, the regularity of the breathing pattern was lost. He was, and the speech was also affected because of the dyskinesias. And I asked the wife, do you recognize what is happening? Sadly, she says, no, I have seen that for the past few years on and off, but I never understood that. I thought that it was just part of Parkinson's and nobody did anything. Well, again, I hope she's watching this program today, because this is why you guys need to learn and need to identify this and judge your own response to medication and demand better response from your doctors. These kinesias are also quite embarrassing for many of the patients, and they don't like to go out when they are having these kinesias. And there is very effective treatment for that today that your doctor should discuss with you. Okay. Now, let's talk about this situation that we see so often of patients taking immediate release carbidopa, libodopa 3 times a day, and then 4 times a day, and then 5 times a day, and 7 times a day. I have patients that even in the past year, even earlier this year, I have patients coming here for the first time taking 8, 9, and even 10 doses of Libodopa a day. And guess what? Here are 2 graphics for you to understand that as time passed by, okay, we have an increase in the percentage of patients experiencing of or motor fluctuations. 20% of patients develop motor fluctuations, and this is a conservative figure within the first 5 years. And then more than half when they are between 6 and 10 years. And these are, again, conservative figures because I have never seen a patient with 10 years with Parkinson's disease that is not experiencing motor fluctuations. But guess what? Even more interesting is that we doctors know, that the risk of developing Offtime increases kind of in proportion as the amount of Libodopa and the number of doses that we use a day. So this was, by the way, demonstrated more than once in the past, including as far back as in 2004, when there was a very well study conducted to demonstrate that motor fluctuations increase depending on how much Libodopa you are on. The motor complications, not only fluctuation, but also dyskinesias. And so if we know that, we should find ways to optimize your treatment using what is called rational polypharmacy. In other words, we shouldn't be just taking more and more and more and more Libodopa. There are drugs that combined with Libodopa could help you to reduce the off time without necessarily increasing the dose of Libodopa. Be aware that the higher the dose of Libodopa, the higher the incidence and the severity of the dyskinesias. So the question is, what formulations of Libodopa are you using? Are there better formulations of Libodopa than the immediate release? Are we able to treat patients thinking not just about today, but in the long term? Are we able to combine Libodopa with drugs like istradefylline or Nurians, which reduces the off time without necessarily increasing the dose of Libodopa? Those are questions that you need to ask your doctors. Now, I dare to say that 90% of the audience is on Libodopa. And I will tell you that 100% of you will be eventually on Libodopa if you are not already on this drug. Well, Libodopa has been prepared in many different ways. And ever since the initial formulation of carbidopa, Libodopa in the 1960s and the approval of the so-called Sinemet in 1970, we have had many formulations. And I'm going to show you how they work and how they do in terms of the concentration in the blood and the duration of the effect. This is the pharmacokinetic curve of the famous Sinemet or immediate release carbidopa, Libodopa. You take the medication and quite rapidly you get a very nice peak and your symptoms improve, okay? This peak then goes down and in a matter of 4 hours, you are basically with very little Libodopa in the plasma, and down there is nothing, and then you are running an empty tank. But you don't need to be here to be empty tank. Right here, your symptoms probably are not well controlled, or they have re-emerged if you are in the middle of the road, not necessarily in the earliest stages of Parkinson's. Why? Because if you are in the earliest stages of Parkinson's, your brain still has the ability to release endogenous dopamine at its own when the concentration of Libodopa is going down. So you don't notice the need for your second dose in the early days of Parkinson's, okay? However, when your disease is more advanced, you will. Now, there are studies showing you guys that 50% of patients treated with Libodopa will experiencing motor fluctuations within 2 years of being on Libodopa, specifically the IR formulation, okay? Now, this is the pharmacokinetic curve of the IR. Now, this is what was created later on, trying to make it last longer. Because remember, what we want is the good effect of the Libodopa lasting longer, so our symptoms are better controlled more steadily for more hours a day. And I don't have the ups and downs. I don't have the, yo-yo. I don't have this pulsatile stimulation, but a more steady course of action, okay? And the a famous cinnamon CR or carbidopa-levodopa ER, which is still used by some of you, is the worst formulation of carbidopa-levodopa ever created. Only pushes the curve a little bit to the right and is so erratically absorbed that when it was compared with IR in the 1990s, it was worse in terms of the motor complications and when compared with the IR. So here is the medication that many of us put a lot of faith when we were working on that 20 years ago, which is the triple combination, carbidopa, levodopa, and entacapone. Entacapone is a chemical compound that prolongs the duration of the levodopa effect by a little bit. As you see, it's pushing the curve again a little bit to the right. And this area here, we call this the area under the curve, which means how much levodopa effect is under that curve, okay? Or how much levodopa is there. The area under the curve is 30 to 40% larger in the triple combination than in the IR. However, sadly, when we tested this, comparing IR versus triple combination in patients with early Parkinson's disease that needed levodopa for the first time, the double combination, the IR, was better than the triple combination. And the reason for that is most likely because the triple combination did not resolve the ups and downs of the levodopa that we don't want to see. We don't want this up and down, up and down. We don't want that. So here is what came on in 2015. And I am amazed. I am just amazed, not to say disappointed, of seeing patients in my office, new patients coming, and they have no clue of this new formulation of carbidopa-levodopa called Raitari. And this medication, as you see, is prepared different. It's the same combination, carbidopa-levodopa, but look at what happens with the concentration of levodopa. My goodness, Lord, look at this. 6 hours later, we are still in very effective levels of levodopa. And this is a formulation that in patients with early Parkinson's disease that need levodopa, you could use 3 times a day, 6 hours apart. And in more advanced patients, 4 times a day, 5 hours apart. Why? Because by the time the first dose is going down, the second dose is already up, and then you maintain levels of levodopa in plasma more steadily throughout the entire day. So this is, in the opinion of most of us involved in the management of Parkinson's, the best oral formulation of levodopa that we have ever had created, okay? And if we believe that the pulsatility of levodopa is responsible for worsening of the dyskinesias and motor fluctuations and so on, the less we have of that, then the better patients should do. Imagine if I go ahead and give you from day one an infusion of levodopa continuously in your intestines, you know, then you won't have motor fluctuations at all. But I cannot do that, obviously, because there is no need to give you Duopa from day one. Duopa, as some of you know, is the intestinal gel that we use to treat patients with advanced Parkinson's and motor complications and so on. It's just one more way to treat those patients, but we don't need to do that early on. Okay, so Raitari, when we have tested this in clinical trial, improve or reduces the off times twice as much than the optimized dose of IR. So again, guys, this is a game changer that we received approval by the FDA in January oh, excuse me, it was at the end of 2014, and it was commercially available in January of 15. Okay, now let's talk about another problem with Parkinson, the dyskinesia. This patient is showing you here mild dyskinesia, moving her head, the upper body, you know, the hands, even the legs move some, but these are peak dyskinesias, and these are mild. Now, you don't need to have severe dyskinesias to be treated for. And you don't really need to use the all treatment for dyskinesia that was, well, if the dyskinesias are caused by high levels of Libodopa, let me reduce the Libodopa at the expense of worsening your motor symptoms, and then the dyskinesias will get better. No, we have to improve the quality of your own with dyskinesias, a medication called Gocovri, which is the new formulation of amantadine. It is better tolerated than the other formulation, and it works beautifully. Once a day, you take the medication at night, and look what had happened here in terms of the results of the studies comparing Gocovri with placebo. At the end of the studies, patients who were experiencing dyskinesias improve or increase the on time without troublesome dyskinesias, or the good on time, to 12.2 hours versus 9.6 hours in the placebo group. And the dyskinesias were minimized to only 1.4 hours versus 3.1 hours in the placebo group. And the off time, which is even better, was reduced down to 2.4 hours instead of 3.1 hours of off time of the placebo. So Gocovri will improve your dyskinesias and also reduces the off time. And here is another way to look at the improvement when we are looking at Gocovri reducing the dyskinesias without the need of reducing the Libodopa. Here you get the placebo, and in 2 weeks, you see what is called separation of the curve, and the Gocovri patients improve at the end of the study 41% versus 14% improvement in reduction of the dyskinesias. If you adjust the placebo effect, you have a 27% reduction in the dyskinesias in those patients. Okay, now for the off time, we also have what we call these days on-demand therapy or rescue therapy. And these are medications that are available for you guys to help you when you go off or when you are running out of gas. The first one that was approved was Applekin or Apomorphine injections. A very effective drug, underutilized in this country, and we are trying to get this drug approved in this country as an infusion or as a pump, like an insulin pump. But as long as we have so many attorneys in Washington, it's going to be very difficult to get this drug approved. And let's just leave it there for now. But this drug is approved as a pump or as an infusion in Europe for many years. And the advantage of apomorphine injection is that you use this when you need it. And the effect starts in 5 to 10 minutes. So if you are wearing off and you inject the medication within 5 to 10 minutes, you are fully on again. And that benefit lasts for 1.5 hours. Now, this medication, apomorphine, has been also made now sublingual. And it's like a listening strip that you put under your tongue, and then the medication is dissolved. And again, you see here how, when compared with placebo, the patients, this is the Unified Parkinson's Disease Rating Scale. This is the examination for Parkinson's. And the lower the lower the number, the better the patient is. So see, here is the patients improving on the Kimobi, which is the brand name of sublingual apomorphine, versus the placebo group. So you see that in 1 hour, you see the peak benefit of most of the reduction in the score or improving in the patient's examination. And the benefit lasts easily an hour and a half or so. Okay, then you have Imbrija, which is an inhaler preparation of Libodopa. And this is also a very useful, effective way to treat the off period. When you're running out of gas, you basically use this as an inhaler, and the Libodopa goes to your lungs, and it is absorbed by the capillary blood vessels in the lungs, and within minutes, you may enjoy a great on time because the lungs are not affected as the intestines are by Parkinson's. So not infrequently we hear patients saying, gee, the best quality on that I have recently obtained is when I use the Imbrija, because again, you don't have to deal with the intestines. In a similar way, you could picture patients with the sublingual apomorphine or the injectable apomorphine. They don't use the intestines to be absorbed. Now, 2 drugs are new for reduction of the off time, Nurians and Ongentys, or Istradefilin and Opicapone. They are very different. Nurians is a very gentle, very nice, easygoing drug. It basically, I call it, some people laugh at this, but I call it the gentle geisha because it's a Japanese drug. And it really reduces the off time when compared with placebo for close to 2 hours. It's not a wow drug. It's not a drug that is going to change your life dramatically, but it will help you and is well tolerated for patients who are experiencing off time, particularly off time that are not severely disabling. Now, Ongentys is another drug. I call it the real McCoy because it's a very potent drug in terms of inhibiting the chemical compound called COMT. When we do that, we allow more Libodopa to get in the brain, more dopamine to be available, and we have a better response, more sustained, and so on. Quite often, if not almost all the time in my practice, I have to reduce the dose of Libodopa before I introduce Ongentys because how much enhancement of the dopaminergic effect I get with Ongentys. Okay, and this is the Duopa, which I briefly mentioned. This is the intestinal gel that basically is a way to provide patients with what they need for 16 hours a day in which you are going to be on with minimal or no dyskinesias, as well as you and your doctors work into the dose and the process of adjustment and so on. Okay, and this is not experimental, it's very effective, and I encourage you, if you have advanced Parkinson's disease, to discuss with your doctors the pros and cons of this modality of treatment. Surgery for Parkinson's is also a great way to reduce dyskinesias and reduce the off time. The surgery does not substitute the medications. There are pros and cons. You need to understand that not all patients are candidates for it. We have now more evidence to support or demonstrating that DBS may be able to somehow slow the disease progression that is being discussed and shown in some studies conducted by the group at Vanderbilt in Nashville, Tennessee. Now, keep in mind that there are patients, as I mentioned, that are not candidates for DBS, particularly those patients with significant cognitive impairment or with limited health. Here you have a picture of a patient of ours. This is in October 18, 2016, and he's coming to see us to the United States, and he is off at the time. He cannot walk, and he is holding the hands, the arms of the wheelchair because of the tremor and the tightness that he has, almost pushing himself back in the wheelchair. We work with him, we change medications, we adjust medications, we perform bilateral deep brain stimulation, and look at him on April 18, 2018. That's less than 2 years, a year and a half later. Look at him, you know, night and day. Okay, and this is not impossible. This is not like 1 in a million. As long as you are in the right hands as you're treating neurologists, you should be able to discuss if you are or not a candidate for DBS, when to have it and why, and what to expect. And I am now at the end of this presentation, and I made it in 1 hour. Okay. Oh,
you did fabulous. So, okay.
Open for questions.
Yes, we do have some questions. So the first one was, I know you reviewed several of the medications, and one person wrote in that they had heard from a previous doctor that they are currently developing a device similar for diabetics, where you stick it under the skin that delivers a steady infusion of carbidopa and levodopa. Do you know anything about that?
Absolutely. Our site is participating in one trial right now for that subcutaneous infusion. And we participated in another trial a few years ago for a similar product. And we expect that the one that is being tested right now will hopefully be approved within the next year or so. That's our hope. And just like the person in the audience say, it's like an insulin pump, and it just delivers the Libodopa in the subcutaneous tissue. And then you change the cannula every 3 days, and it works. It's Libodopa. And by the way, it works continuously. So you are on all day long. And you are able with your doctor to adjust the dose in such a way that your dyskinesias should be minimized or non-existent.
There was also a question, I know you talked a lot about being at level 10, were the lights too bright when you were reviewing your dimmer switch. And one person wanted to know if you could discuss muscle spasm pain with high levels of Sinemet intake. This can include shaking.
Yeah.
What do you do? Reduce the Sinemet? I think you just talked about some of the options.
Well, muscle spasms on high doses of Libodopa, I bet that the person in the audience is referring to dystonias as part of the dyskinesias. Dyskinesias may involve spasms or cramps to the point of being painful. So yes, dystonia in dyskinesia is not uncommon, and the patient needs to be treated accordingly. And it is hard for me to tell you, oh, you're going to have to reduce the dose of Libodopa, because I don't know how this person is in general. But there are drugs like Gocovri that could help reducing all of those things. And not uncommonly, if a person has severe dyskinesias, you may actually reduce the dose of Libodopa without sacrificing the quality of the on, or without increasing the off time, and then add the Gocovri to subsequently reduce the dyskinesias and reduce even more the off time. So the other thing is that if somebody has severe dyskinesias with dystonia and pain and so on, that's one of the reasons to use deep brain stimulation as long as the patient qualifies for. But see, it's impossible, Anissa, it's impossible to answer how do I treat John Doe there in the audience, because everybody is a unique individual. And again, if you are not satisfied with the food of this restaurant, go to another.
And that's a really good point, because there was earlier a comment made that this person was experiencing the symptoms, all the symptoms that you were describing, that they had confirmed Parkinson's, and because of an atypical symptom or just the way they present, now they're being told that they may not, and they should get off medications. And I think you just answered it. Like, if you're not satisfied or you're not sure, what would you tell somebody if they...
Listen, guys, don't get me started with politics, but every country deserves the government that they have. And that's it.
But the person who's not satisfied or not getting the answers, I think like you said, if you're not getting what you want from one place, go to another.
Get a second opinion. Go to, there are good and bad restaurants everywhere. There are good and bad restaurants, good and bad hotels everywhere. So you have to make up your mind, and you have to fight for your rights.
And that kind of leads into another issue. There's a lot of really great treatment options now for Parkinson's.
More than ever.
Which is fantastic. But for some people, it's really expensive. Any thoughts?
No, let me put it like this. All these companies have programs that provide financial support. They do that through the own company and or foundations. The very, very, very exception to the rule is a patient that is being told, listen, you make so much money that you need to pay X amount of dollars in addition to what we and the foundation is providing. The problem is that the patients are being told by, I guess, physicians or clinical staff, oh, it's too much paperwork. And that is very depressing, because if paperwork takes to take care of my mother, I'll do the goddamn paperwork. It's my mother. So the same thing you need to expect from your doctors.
And we're going
to... By the way, the doctors don't do the paperwork. We sign a form. Mm-hmm. We have a staff people to do the rest and to fax these things and so on.
And we do at PMD Alliance on our website. We'll drop the link in the chat. We do have a list of all of the medication assistance programs that are available as well. So if you've not checked out that resource, that is a really wonderful resource to also look into. And I know we're getting close to out of time, but there was a question about your description of off, and if that is available, because people are wanting to know, how do I better track the symptoms? You've given a really good guide. Is when and if that's going to be available.
I was thinking about that last night, and I don't know how can we do that. And I guess probably Anissa and I will talk about it and see if we perhaps make it available through your organization. The one thing that I need to tell you is that I've been advised to write it in a simpler language. And I'm waiting for that to happen. And I have to, again, talk to my boss, Anissa Mitchell, to see when are we going to get this thing finalized.
Well, and it is a really great tool, and I think it can help people to be able to articulate to their physicians a little bit better what's going on, even though it is subjective, as you say in the descriptions.
Hey, Anissa, now I learned the trick, and I'm looking here at the chat. So I'm going to read this question. I've been asked, can we use telemedicine for an initial visit? Well, the answer is no. I don't do telemedicine. That is baloney. I just had a patient that came to see me today from New York, and they're going to spend a week in Southwest Florida. It's your life. Telemedicine doesn't help me to get to know you. I need to examine you, and we need to connect. Now, wherever you are, I will be honored to see you here, but there are plenty of good doctors everywhere. Anissa could help you to locate some of those in your community. But do your very best to avoid this telemedicine. That's my opinion. I know that there are very famous people out there loving telemedicine and promoting telemedicine. I don't believe in telemedicine. All right.
All right.
What else? Yes.
Thank you. And so I know that we're out of time, Dr. Gil. So okay. I want to thank you for giving your time, and I'm going to unshare your screen. Because I think it's important for us, even though we are in video and we're little boxes, to see everybody's faces. And I know that we didn't get to everyone's questions, but I think you've covered a lot of this information. So thank you so much for sharing this and your concept of the dimmer switch. Because again, I just think that is such a unique and quite honestly, a really good description of probably what people experience. Is not just one thing to another. It's very many shades in between.
And then you could also communicate better with your doctor and say, you know, I am kind of a 5, I'm a 4, I need more. It's kind of a better way to judge your own motor response. All right.
And I know if you have any additional questions, folks, that you didn't get answered, I know there was a few, feel free to email us at info@, we're not physicians, we're not going to give you medical advice, but we can give you guidance as to maybe how to ask your physician a question, or where, if you don't have a treating physician, you can go. If you need to find one, we definitely can get you connected in that manner. It's very important for you to get into a situation where you have a good working relationship with your physician, that you can communicate with them. And for the care partners that are on this program today, for you to understand so that you can support your loved one in articulating what those experiences are, so they can be addressed. Because again, going back to all the things that Dr. Gil discussed, that quality of life for your loved one is directly correlated to your quality of life and its impacts on you. So feel free to reach out to us. Dr. Gil, we have our tradition at PMD Alliance of the wave of gratitude to thank you. So I'm going to invite everyone to turn on the cameras if they don't have them on, so we can see your lovely faces, and give you the wave of gratitude to thank you so, so much.
You guys take care and don't give up. Don't give up. All right. Bye-bye.
Bye. Thank you, everyone.